All right. Well, good morning, everyone. My name is Maureen. I am a nurse practitioner here at St. Luke's, and I am here to introduce our Chalk Talk for today. Welcome to the Chalk Talk. Our Chalk Talk today is based on an article from the Journal of Palliative Medicine. It's called Top 10 Tips Palliative Care Clinicians Should Know About Navigating the Needs of Adults with Intellectual Disabilities. And we are fortunate to have two of the authors here with us today. Caitlin Moore and Dr. Caitlin Moore and Jane Tobias. Dr. Caitlin Moore is dual board certified as an adult gerontology acute care nurse practitioner and advanced certified hospice and palliative care nurse. Dr. Moore is an assistant professor of nursing for graduate programs at Thomas Jefferson University College of Nursing. She is also pursuing her PhD in palliative care from the University of Maryland, Baltimore. In addition to her faculty role, Dr. Moore maintains clinical practice as an inpatient palliative care and hospice nurse practitioner in the Philadelphia region. Dr. Moore is passionate about palliative care, nursing education, and improving palliative care for people with intellectual disabilities. Dr. Jane Tobias is an assistant professor in the Jefferson College of Nursing at Thomas Jefferson University in Philadelphia. She has been educating nurse practitioner students in the academic setting and providing pediatric primary care, clinical mentorship, and experiences since 1999. Dr. Tobias's clinical interests are deeply rooted in the care and advocacy of individuals across the lifespan with neurodiversity. She is a fellow in the Golisano Institute in Developmental Disability Nursing. She brings her primary care pediatric expertise to the Jefferson Center for Autism and Neurodiversity, where alongside Dr. Wendy Ross and her team, she focuses on creating inclusive healthcare access for individuals with autism spectrum and intellectual disability. Welcome to you both.
Welcome. Thank you.
Thank you. Thanks for having us.
Glad you're both here. So maybe tell me a little bit about why we are here today.
First of all, for the invitation, thank you for having us. We're excited to be here today. Caitlin and I are both healthcare providers, and as you just described, I am at the younger pediatric end, and Caitlin cares more for the older adult end. But we both have that passion for creating access and care for those with intellectual disabilities, and that does extend across the lifespan. And we found that intersection of where both of our areas of care and expertise came together, and that is really the kind of brainchild behind the article that we worked on talking about 10 top tips for palliative care for individuals with IDD. For me, my background was always in caring for children, adolescents, and young adults with intellectual disability, developmental disability, neurodiversity. And we know that the prevalence is going up. It's increasing in the communities. And part of that is because of some of the success we've had in creating more care access. There's about 19 per thousand individuals in the US diagnosed with an intellectual disability. It crosses all ethnic and racial lines, but we do see it more in males and females. Globally, that number is a little lower, but it's important to mention because we have a lot of providers that work along the border that have a lot of individuals immigrating into the country, also from around the world that have intellectual disabilities. And to be able to recognize that and also make sure they're getting the care that they need and they deserve is important to us.
Great. Yeah. Really, we're talking about our people, right? Our patients, family members, friends, communities. And thanks to these advances in healthcare, as Jane mentioned, people with IDD are living longer than ever before in history. However, generally speaking, there are still higher rates of premature death among this population. So while people are living longer, they're still dying sooner compared to the general population. And much of this comes with increased impacts of serious illness and rising palliative care needs. So we're talking about a historically marginalized population of people who are often left out of decisions and discussions, both involving their own lives as well as the lives of the people that they care about. So it's really important to Jane and I to bring awareness to this group through our work and to to work together to find more inclusive healthcare and palliative care practices. And I think what we really hope is for our discussion today to stimulate more discussions amongst your own groups on how to improve palliative care for this population.
Excellent, and more awareness too.
Yeah.
So what are intellectual/developmental disabilities, or IDD as you're calling it?
Yeah, so IDD really covers a large span. And just to kind of provide a little foundational knowledge, an intellectual disability typically occurs before age 18, and it is usually diagnosed or observed at birth or soon after birth. And IDD is not a single disorder, but more of a term that's used to describe kind of a continuum of neurologic dysfunction and a range as well. For many individuals, they may have a significantly reduced ability to understand new or complex information. They may have communication differences where how they communicate is very different from what our perception of it should be as well. And that I kind of think of IDD into two categories. Those categories are, is it inherited? And when we think of inherited, we think of genetic causes. For example, Fragile X, trisomy 21. Or is it a result of being acquired or the environment? And in my world, we see that a lot with babies that have fetal alcohol syndrome that go on to then be developed with an intellectual disability later in life.
Yeah. One big takeaway for me, especially not being in the peds world and much of my adult gero training, didn't really have a developmental focus, was being really explicit in my understanding that IDD, and we use those terms interchangeably, intellectual developmental disabilities and IDD, is not a disease. It's a disability. And I think most of us know this intuitively, but when we really think about that, we're talking about two different aspects of a person's experience, right? So I don't pretend to speak for everyone. We don't do that here. But for many, disability is not something that's meant to be cured or fixed, right? Like we might commonly emphasize or seek with the aspect of disease. IDD is a part of who people are, and it's just a different way of being in the world. And it's a natural part of human diversity. IDD is a natural part of human diversity. So this recognition, again, was intuitive, but had that aha moment when we would have some of our discussions early on. And it really created a mindset shift that's important because it fosters respect, inclusion, belonging. And that's particularly important for us as healthcare professionals to be explicit in this understanding and to embrace that idea that IDD is not something to be fixed. And it's not something that we should be casting, value judgments on about what quality of life might mean for an individual. Instead, we should be accommodating and celebrating disability in all of its various forms. So this view of how we see our patients and the lens through which we view that does impact how we treat them. So it's important to have that distinction, right?
Yep. It is. And it's important also to remember, as I said earlier, IDD has a range, mild, moderate to severe and profound. And many of the individuals that we work with, many of our patients fall into that mild to moderate range. And, the difference is very, very little. It's very subtle, and it really just comes down to communication. We're going to talk in a few minutes about some strategies as providers, how we can change the way we communicate. We have to think about what we can start doing differently to accommodate those with IDD. And also, you heard us use the term neurodiversity. Really, that's anybody that thinks or acts differently. And if you think about it, probably everybody in this room on this screen will encounter a form of neurodiversity. Aging is considered neurodiversity, dementia, a concussion, somebody undergoing chemotherapy that might have that chemo brain or brain fog. And it's just a way of how we should start practicing without having to put a label on somebody that they have IDD or they have a neurodiversity. But more importantly, what can we do to provide care that is more easily accepted and less challenging for somebody to access?
So that leads us to the next question then. So what
Yeah.
are some things that healthcare teams can do to improve care and support for people with the IDD?
Well, I often think about, social determinants of health, and in that, falls education, housing, nutrition, transportation. And if you start thinking about those aspects and then somebody's health care, it comes down to, and as a primary care pediatrician, I'm a big proponent of preventative care. And if we can start providing more preventative care, increasing that access, thinking about how is our patient going to get to the office to have their annual well visit? How are they going to manage scheduling a colonoscopy or a mammogram or have their annual GYN appointment and pap smear? And if we think about prevention, then hopefully at some point they may not be seeing Caitlin in palliative care or hospice care as soon as they are. Their life expectancy will be longer, it will be more fulfilled. So that's a big kind of area that I really have focused a lot of my own practice in, is creating more access. And as Caitlin said, inclusion, and more importantly, that sense of belonging. We're not doing this because of your disability. We're doing it because you deserve it. Everybody deserves to be able to access their healthcare provider easily without it being a challenge, without it being a stressful or anxiety-provoking event.
And I think, within palliative care and much of healthcare, there's really a two-way street here that we can go down. And most palliative care clinicians understand the frustration around things like there's not education within training programs, residencies, fellowships on good end-of-life care and palliative care. And the same is true within this community, within intellectual developmental disability advocates and experts. There's just so much that we're not taught about and that we don't know about. And this is an opportunity to really connect with experts on both sides, right? And definitely partnering with people and families and clinicians who care for people with IDD. So this includes, opportunities to educate direct support professionals and caregivers. So when that person, is admitted to the hospital and they have their direct support professional at the bedside, educating them about how the differences between palliative care and hospice, or the resources that might be available to them in your communities. There's a lot to impart here, and coming in the other direction, there's so much that we can learn from them by bringing them into things like family meetings, making sure that we're getting their opinions, because they're often very important people in the lives of individuals with IDD. There's also there's actually some research that shows that the death of a person with IDD is often what they term unexpected. But when they go back afterwards and they talk to the people caring for them and their families, they are able to actually recognize some of those changes over time and some of that progression that we see in the the usual trajectories of diseases that we're used to. So for example, people with certain intellectual and developmental disabilities are at much higher risk for dementia, right? So with that, that's our bread and butter as palliative care clinicians, right? That educating and partnering and making sure that they understand and see, some of the things that they can really identify those needs earlier for folks, so that they can, have better access and more appropriate access to palliative care and even hospice when the time's appropriate. So the opportunity for partnership is really tremendous here, and how we can improve this. And that two-way street, I think, is really a breeding ground for collaboration in this space.
Yeah, and Caitlin, you hit on a great point about partnership within the medical community, but also it extends into the person's family life. Their direct support professionals, which, by the way, it's Direct Support Professional Recognition Week. So I really wanted to say thank you to all our DSPA folks out there that are really supporting our population. They are like family. They should be at meetings. They spend a lot of time with these individuals. And just remember, you can't be a silo when working with the IDD community. You really have to have touch points both inside the medical area and outside. And a lesson I learned early on when working with Dr. Ross at our Center for Autism and Neurodiversity is people first. We have to ask what their perspective is and not assume what we think they want. For example, instead of asking, what's the matter? What's bothering you? You want to rephrase that and say, what matters to you? What do you want? Caitlin and I, when we were up at the conference, I believe somebody had shared a story that somebody had entered palliative care. And, the one thing that they missed that they always wanted was they used to go to McDonald's, right? And have that hamburger every day. And nobody thought about it until somebody said, well, what do you want? What matters to you? What is your goal? I just want to get back to McDonald's and see my friends and have my hamburger every day. That's what I want. And, again, ask the person what matters to them and what they want and what their goals are.
Great. So what are 2 or 3, I guess, in addition, other important clinical considerations for palliative care professionals caring for people with IDD?
Lisa Iazzoni, I don't know if anybody's familiar with Dr. Iazzoni. She's the director of health policy up at Mass General Hospital, has done a lot of research, very informative research on health disparities among people with disabilities. And a couple of years ago, she published an article. For me, that was really kind of that gut punch that opened up my eyes to where we need to do better as healthcare providers. And in that article, she interviewed about 750 physicians and asked them about caring for individuals with disabilities. And this includes more than intellectual disabilities. And 82% responded that they felt people with significant disabilities had a worse quality of life than those without. And about 40% were confident that they had the ability to care for this population. So first of all, I applaud the honesty and the transparency of those interviewed. And it really showed me that we have so much work to do in this area. It's really important that we do more research about perspective. We do more research about inclusion. And also, this goes beyond what we do in our day-to-day life. It starts impacting how can we influence insurance companies and payers and reimbursement of time. It's a rabbit hole that is one we need to start going down and start thinking about.
Yeah. And I think, my palliative care people are really good at considering the whole person, assessing quality of life, and really advocating for and taking individualized approaches, right, to patient care. But advocating for your patients with IDD about what their quality of life looks like and bringing that to the awareness of the teams that are consulting you is critical here. As Jane mentioned, there's these barriers of bias and this lingering history of really discrimination that exists towards this community. And we as healthcare professionals are not immune to it. She mentioned the Iazzoni articles, but there are articles that also point that this exists in nursing as well. So it's something we really all need to keep in check. And there's this concept of diagnostic overshadowing, and that's common and particularly impacts people with IDD. And there's a range of examples here when we're talking about diagnostic overshadowing. It can be something like a clinician, something serious like a clinician who's actually basing their prognosis on the presence of disability rather than disease. It can also be something like a clinician who, has a patient with behavioral changes and they decide to medicate that rather than investigate that. Right. So you can have a person, with IDD who's demonstrating behavior such as, hitting their head, or potentially some other, violent behavioral changes. And it's thought that the answer is sedating medication, right? In reality, it could be something like a tooth abscess or an ear infection that this person may be unable to articulate in a way that you can understand. So, having that awareness and checking things within yourself is really important here. And this is where, we always like to mention really some legal considerations and ramifications. So I'm going to share my screen for just a minute. And, this is a resource that we share with folks, because we need to remember, because of this lingering history of, again, discrimination, there are legal safeguards and systems in place regarding end of life and medical decision making for protected patient populations. So we like to share this because, it varies state to state. So, be sure to identify the agencies, the state's intellectual and developmental disability agency contact information, that you can access using this QR code or typing in that website to figure out who's in your area. And remembering that we want to first assume capacity and support autonomy whenever possible, while also balancing, protecting, and aligning with the legal safeguards that are in place. And we recommend engaging these entities early and often in these cases. Go ahead.
I was just going to say, that is an excellent point, Caitlin. And we developed a tool called the Health Resume. Some people may be familiar with it also as a health passport. And we geared it towards individuals with intellectual and developmental disability, but also it really benefits anybody. And it's a patient-centered survey that we have our patients complete. And it's really about their preferences for healthcare. How do they communicate best? Is it easier for them if a provider speaks slowly or breaks a question into separate parts and gives them 1 or 2 minutes to respond to that question? So many times we're always looking at the clock and we don't always give our patients enough time to reflect on a question, think about how they want to answer it and respond. It talks about, when I'm in pain, these are the things you may see me do. They may not be what you typically experience. I will curl up into a ball, or I will get really silent. Or if I'm having my blood drawn, or if I'm having my x-rays taken, I get very anxious. Headphones help me to calm down. So we started using kind of this health resume just to get more information from our patients about what matters again to them. And also, many of our patients are in our cancer program, in our oncology program. As Caitlin had said earlier, trisomy 21 patients are prone to leukemia. Lack of preventative care has them coming to us in the cancer center. And being able to, have a glimpse into somebody's life without knowing them really well is so helpful for that first meeting with a patient. Some of them may have 2 or 3 different providers they see in a day, a different phlebotomist, a different nurse. And if you can just kind of read their resume, which is really brief, but gives such great insight into their preferences and what they want and their goals, it just makes for such a better visit for them. And, hopefully better outcomes at the end, that they have a sense of peace and they have a sense of being heard through their care.
I think maybe the last kind of clinical consideration for our palliative care specialists in caring for people with IDD is symptom assessment. First and foremost, recognizing that many people with IDD can self-report pain and other symptoms. So they should first and foremost be asked. And it might be, in different ways than you're used to Jane's point. So it's not, when did this start? If you have a person who maybe doesn't process time that way, go back to familiar dates. Did you have this pain at Christmas? Did you have this pain at Thanksgiving, right? Try to help them find landmarks to help you interpret their story, right? But really believe them, right? Pain in this community, for example, can manifest as, behavioral changes. So it warrants physical exam, health history, and behavioral assessments. You should always do an appropriate workup. And then really including family members, caregivers, those direct support professionals, other people who know that individual well. A lot of times a parent or a caregiver will say to a provider, something just doesn't seem right. Something's not right. Investigate that. Get really curious. Ask more about what they notice. What's different for your loved one today. There's also formal assessment tools, and we mentioned this in our article, and we have links for that there. But two in particular are the non-communicating adult pain checklist, and that's used in a couple of different populations. It's not specific just to this community. And there's also the DISDAT tool, which stands for Disability Distress Assessment Tool, and it's really individualized as it serves to document really the numerous signs and behaviors of distress and also comfort for that person. So I think Jane gave some really good examples of that too.
Yeah, and another great pain assessment is the pediatric pain profile. And although it has the word pediatric in it, it can be used up into, I believe, the mid-60s. And what's neat about this tool is that it captures the person's pre-pain assessment, and then you compare it to after they've had a procedure, or if you know their pain is escalating. So it's very helpful, and it can be completed again by the person themselves if they're able to self-report, or by their caregiver. And that it's just important to note too that individuals with IDD, many of them experience chronic pain and don't recognize it is pain. So it's really important to stay tuned into just subtle behavioral changes, subtle communication changes as well.
So in closing, thank you for that. Can you share 3 pearls with our audience as a takeaway that we can use as we move forward?
Yeah, absolutely. We work with a wonderful family medicine doctor at Jefferson, Dr. Mary Stevens, who runs our complex care clinic for individuals with IDD. And she's just a huge advocate for this population, and is one of the few in our area that actually has a care clinic that welcomes these patients from the pediatric home now into the adult medical home. And she said, she's taught us that having an intellectual disability does not automatically preclude an individual from giving informed consent, but nor does the lack of a guardian or conservator automatically mean an individual is capable of giving consent. So a lot of words there, and I think the take-home message is clarity. Just be very clear, be proactive rather than reactive. Get the information you need before things escalate in somebody's care. Talk to your patients, particularly if you're working with the younger population before they turn 18. Talk to the families about consent, assent, guardianship, and some of the legalities. And it does vary from state to state, as Caitlin mentioned, but be familiar with that.
Yeah. I think the concept of breaking bad news, or what I prefer to call, discussing difficult news, can be challenging for clinicians, especially and amplified with, people with IDD. Well, sometimes I'll get questions from families or even other providers, should we tell Danny or whomever about the cancer? Or a parent in fear who's asking us not to tell their child, even adult child with IDD, that their father is dying. And I think, those are real missed opportunities for inclusion and engagement. And this is where I'll share the screen again. So thinking about inclusion that involves death education and preparation. So decisions to disclose difficult news to people with IDD does require careful consideration. There's no one size or, one approach that works, but there is a common misconception that discussing difficult news with people with IDD could increase psychological harm, or that they're incapable of understanding things in meaningful ways. And really, I think for most people, especially parents and caregivers, it comes from a really good place, right? They don't want to hurt or cause more harm to the person that they care about. And they're wanting to really protect that individual. And that leads them from shying away or not having these conversations at all. But we know that when people with IDD are not informed about the illness or death of a person whom they have a close relationship with, they can be denied, the opportunity to prepare, to have meaningful interactions, to say goodbye. a lot of the things that many of us want during those precious times. And research has actually demonstrated that when supported properly, talking about end of life does not cause or increase psychological harm. It can actually decrease anxiety for people with IDD. I have a good social work colleague, Arlen Gaines, who reminds us that disability does not shield people from grief. So just because you're not talking about it doesn't mean that it's not happening or that this person isn't experiencing things. People with IED are at an increased risk of experiencing what we call, and again, borrowed from our social work colleagues, disenfranchised grief. So that's grief that's not socially sanctioned or publicly validated. Here, the loss is not recognized, the griever is not acknowledged or included. And this comes up when people with IDD are not told the truth about death or are mistakenly viewed as unable to grieve or to have any kind of grieving process. And again, this leads to them being excluded from important things like rituals, community support, death education, again, having those meaningful moments. So we really advocate for a process of individualized disclosure. It's not all or nothing. It's not tell them or don't tell them. The first step, for people seeking to protect people with IDD from bad news is to recognize your own discomfort in this and try to move beyond your own fear or help that patient's family member or caregiver move beyond their own fear of unknown reactions. It's important to remember that many people with IDD are resilient. They've experienced loss. They've experienced transitions and changes in their lives. And, previous life experiences can be drawn on here and brought to light to help that individual understand. That's really what's called the strengths-based approach, again, from our social work colleagues being critical here. Find out what's comforting to this person in other situations. How have they managed other big transitions in their lives? Who is helpful to them? Who's that person that might bring them comfort? Who is their support system? And then using concrete, simple language, avoiding metaphors, saying things like she has died, her body is no longer working, is appropriate in some of these situations.
And then I think kind of the last tip to share, it's not really a tip, but self-reflection. After you've worked with a patient with IDD and their family and their caregiver, just, take a quiet moment to sit back and say to yourself, what did I learn about this experience? Folks with IDD and their families are such great educators to us as healthcare providers. And that's where I learn my most from. You can read what's in the textbooks, you can read the articles, which, provide you with strategies and background in the research and the data. But it's really that lived experience and sitting in the middle of decision making and just quietly listening and reflecting back, I think, is where we gain our greatest knowledge from. And, for all of us, sometimes this is a new experience the first time you work with a family or an individual with IDD. So it might be a little uncomfortable. So ground yourself with a great team. Afterwards, sit down with your team, with the chaplain, with the social worker, with the nurses, with whomever was in that experience with you, and talk about what went well, or talk about those things that you wish maybe had been done differently, or if we had known sooner, we could have done something proactively. That's where we're going to gain our greatest knowledge.
Yeah, be kind to yourselves. We're all here learning, right? And to get it right, not be right.
I like the debrief. I think that's great. We have just a couple minutes, I think, for questions. I know Martin had said he may have had a question, but that's a lot of great information. Does anybody want to ask a question?
Many of us have students, fellows, learners of all sort of types. How do you help them or even ourselves get better at recognizing our own bias? I mean, what are you asking? How are you doing this stuff in the hallways after these meetings?
That's a great question.
Yeah.
So go ahead, Jane. You can.
No, you start, Caitlin.
Yeah. One of the biggest things that again, with learners, but even with our colleagues, right? So many times I'll get a consult, for example, and it'll be, a person with IDD and they really need palliative care. We think it's time for hospice. And I know that's a complicated process. So can we get it started? Right. And I'll ask for more information. And that's where that diagnostic shadowing piece really comes up again. And it will be, well, she's not walking. She hasn't walked. And, that person maybe never walked, right? But they lived a full, engaging, meaningful life. So being that advocate, right, in that moment, and bringing that to the other clinicians' awareness, and making sure that we're separating again that piece of disability versus disease, right, and not putting our own judgments on that situation. And I think when we can model that and do that ourselves, right? So catch ourselves if we see things are happening, and really asking our questions out loud and to each other. Are we talking about the disability versus disease, right? And what does quality of life look like to that person? And again, we might not always be there right away, but if we're willing to take those moments, right, and have those checks for ourselves and demonstrate that for our colleagues, I think those are real teachable moments. In addition to obviously more formal kind of education and training. And I'd love to hear Jane's thoughts too.
Yeah, I'll speak more to kind of the education and the training piece of it, since that's where I have been putting myself lately. And I'm going to sound old here, but it is the upcoming generation that we have to start focusing our education on. And we all know there's huge gaps in curriculums regarding intellectual and developmental disability, and the nursing side and the medical school side. Right now, I'm teaching a humanities course on disability, and it's a 1-credit course the med students take. And that is where we have these open discussions about intellectual and developmental disability, about physical disabilities. Find the champions in your organization that have some background in neurodiversity, in IDD, and ask them to just come and do a 30-minute brown bag, lunchtime little presentation or a brief case study. Or what we're finding more at our institution is when a patient's admitted to the floor with IDD and a newly diagnosed leukemia or has a tumor and needs to be evaluated, they're reaching out to us to say, can you meet with us and give us some strategies and give us a refresher, a crash course? And, it's not the best, but it's a start. So I think just starting with education and bringing in awareness that you will be caring for this population, particularly in emergency departments. That's the big place, because these folks don't get a lot of preventative care, but they end up in the emergency department, and they end up in bad shape where they're not their best. And that diagnostic overshadowing can occur. So again, start simply, just start with asking for help, having somebody just come in and do a brief little education, and then it will expand, and you'll start to find out who those champions are in your institution and start then just growing.
The last thing, I'll just piggyback there, Jane, because we've done a lot of this advocacy in our own different organizations. Many places have an increased emphasis on DEI and promoting belonging. And that work is critical. But again, this population is so often left out of those conversations, of those roundtables, talks, different initiatives, et cetera. So really looking within your own organization, and even within, DEI committees, is this a group that's being supported?
Great tips. Thank you, ladies. Thank you, Jane. Thank you, Caitlin. We appreciate it. And thank you for everyone for joining us at the Friday Chalk Talk. Have a good weekend.
Thank you
all
so much. Thank you.
Bye.